VVE, we get a lot of phone calls and requests from psychiatric patients about euthanasia or assisted dying, and that is the reason that we started to give attention to that group. Although after the law was accepted 12 years ago, nobody really thought about psychiatric patients, but then after the law came to force, so many psychiatric patients proved to be interested in euthanasia or assisted dying. That's why we went into this group to see what the interests and the possibilities were. And of course we first encountered a culture among psychiatrists that was not at all pro-euthanasia. They felt that not a wish to die is to be interpreted as a wish to live. They felt that if somebody wanted to die, the treatment had not been good enough, and that we should switch to another treatment that should help better. A wish to die was, of course, also seen as a failure of the doctor. Something had not been done well, and we can try again. And of course, it turned out that psychiatrists didn't have any experience in the treatment of euthanasia. Psychiatric doctors don't know how to push the needle in the arm anymore, and that's what you need to know if you want to perform a euthanasia. So this culture in psychiatric environment we had to change in order to do something about the requests of the patients. And we worked on it, for example, by making films with psychiatric patients. We had a beautiful documentary about a daughter who saw her mother jump from a big building, and the mother had asked for euthanasia already 10 times, and in the end she committed suicide. This kind of publicity was necessary to get the public interested in the subject. Also, we gave a lot of attention to mothers who had lost their children because the children committed suicide, and we gave them also a lot of attention in the media so that they could tell their story, how much they had wanted that their children should have had a normal euthanasia instead of having to commit suicide. Another thing we did was that we organized psychiatric doctors who were willing to think about being euthanasia doctors in a support group of psychiatrists who informed each other about how you can perform euthanasia, under what conditions, etc., etc. So there, in the meantime, a bigger group of psychiatric doctors was growing in the Netherlands who were willing to perform euthanasia. And after all these efforts, we can say now that there is no longer the ignorance among psychiatrists of the wish to die, to really wish to die, of psychiatric patients, which is not the same as wanting to commit suicide. There is a tendency to make euthanasia part of the treatment deals. It's not just if the treatment fails well, we will, as they said, open the back doors of the psychiatric institution so that they can call and get themselves under the train. But euthanasia is also a possibility now in treatment deals. And we see specialized psychiatrists. The word is very difficult for Dutch people, as you hear. Specialized psychiatrists who know more about euthanasia, the conditions, and how to perform it. What also was a help is that we started 2 years ago with the Life and Clinic. You may have heard of it, where people who are denied euthanasia but do have the conditions to get euthanasia are helped by doctors from the Life and Clinic. Many psychiatric patients were calling the Life and Clinic, and so a practice is been evolving about how to deal with that and what's possible and what's not possible. And so all these new developments, where of course it was also known in the media and lots of attentions from the public, the subject got a lot of political and public attention. People were talking about it. It was not considered strange anymore if a psychiatric patient asked for euthanasia. And that also had the consequence that politicians talked about it again in the parliament, asking themselves if we started with a euthanasia law 12 years ago, were we thinking of psychiatric patients, yes or no? And the result was that they admitted that indeed the Dutch law also covers psychiatric patients. You see something in the numbers. It's not yet very impressive, but as you see, the numbers are growing, and in 2013 we had 42 psychiatric patients who had euthanasia in the Netherlands. If you know that we have yearly 4,000 euthanasia cases, then it's not much, but the important thing is, of course, the curve here. Of these 42 patients, 9 were being helped by the Life and Clinic, so certainly not all of them. And it shows that doctors and psychiatrists are getting accustomed to the idea. Shortly, maybe it's good to remind you that it's, of course, also these cases are under the condition of the euthanasia law in the Netherlands, which means that the patients have suffer hopeless and unbearably, that there is found no treatment alternative, and that it is within the due care criteria of the Dutch law. And the cases, the 42 cases, are all within these characteristics and were found okay by the committee that decides about it. I keep it very short because you've had already so many long discussions and sessions, but I can imagine that the idea that we are getting accustomed to this group in the Netherlands brings some emotion or maybe questions in the public, how you'd want to deal with it, or what are the possibilities in your own country.
Thank you, Margot. So, we will get the questions there over there. You keep over there. Who has a question for Margot? All right, I come with you and start here.
I just want to, can you say more about the Life and Clinic? I'm not sure what that is.
It's a clinic that we started 2 years ago in the Netherlands. We thought that we needed a place for all our members and who didn't get the chance to get euthanasia, because not all doctors in the Netherlands are willing to do it. I mean, it's possible under the law, but that doesn't mean that all doctors are willing to do it. And therefore we started the Life and Clinic. It's a clinic where doctors and nurses work in teams, and they go and visit the people who have requests at home. And mostly the euthanasia is also executed in the homes of people by ambulance teams. It's usually the Dutch way of euthanasia, which means you get the needle from the doctor, but some are also assisted suicide. And the specifics of the clinic turn out to be that the more complex cases come to the clinic. I mean, if you have a cancer and it's the last 2 weeks of your life, then doctors are willing enough in the Netherlands to help you. But if you have ALS, or you have dementia, or you have whatever complicated diseases, that doesn't finish you off, but are very unbearable, and you are eligible under the Dutch law for euthanasia, but it's very difficult for general practitioners to know how to do it, and that's why this clinic more or less specializes in those cases. And I think Petra, the director of the NVV, has told in the other session already that then what turns out is that if one of these teams of the clinic come to the patients, they always inform the general practitioner or the specialist who's working with the patient, and then it turns out in half of the cases that the own doctor wants to do it. Because then he feels, sustained by the experts. And that's very, very important, because it's a lonely thing to do for a doctor. And that's why now, after the Life and Clinic is also starting with an expertise center to help doctors in the Netherlands to learn more about euthanasia and to help them. So that's the Life and Clinic, complicated cases and among them psychiatric patients.
To say what we learned from Petra in that session is that the Life and Clinic is not a clinic. It's an office, an organization with teams of doctors and nurses who together go and assess the cases and perform the euthanasia or assist. Am I correct like that? I first go to the gentleman back.
Thank you. I visited the clinic during a sabbatical a few years ago, and I interviewed Mrs. De Young, and it seemed to me that the clinic was very professionally managed and very well organized. My question is, does the fact that some psychiatric illnesses have a somatic or physical base, does that help the request to be accepted? For example, today, it is said, although it's maybe difficult to prove, it is said that deep depression that cannot be alleviated through regular means has a physical component to it. Does that physical component help those cases to be accepted?
I'm not a psychiatrist myself, but what I see happening is that the psychiatrists among themselves are starting to talk about these things, and that they want more research on it, and that they're getting into these matters thoroughly. And of course then you get more information and more securities about when it's really a wish to die or whether it's possible to cure it in another way. And we look at it, and we're very happy that this is happening, this development in the Netherlands, and it takes some time to get the right guidelines, but we see that the psychiatric association is trying to work on that. And whether it helps or not, I cannot tell you yet. But next year, if you come, they will know.
Ja,
Well, I'm interested in what kind of diagnoses would be applicable here. And I'm thinking a little bit about the same deep depression in my country. As soon as somebody is depressed, or at least sad, they say he is mentally depressed, deep depressed, medically depressed, and then he doesn't know what is best for him. So how do you look at that?
Yeah, I think that's changing that opinion in the Netherlands. What I see, we had in the parliament a few months ago. We had a discussion. The parliamentarians wanted to talk to psychiatrists in the Netherlands about this development, and I found it impressive to hear so many psychiatrists tell the politicians that depression can be absolutely unbearable and hopeless suffering. And there were tear-jerking stories about patients. And so I feel that certain types of depression are now absolutely accepted as unbearable and applicable under the law of the Dutch. Yeah.
Of the 42 cases in 2000, oh, I'm sorry.
My question is, if these clinics are not buildings necessarily, but teams of doctors that go out, would anybody in the Netherlands, no matter how rural or how far from a major city, would they have access to these life-in clinics for the teams?
Yeah, but the name is still a bit strange because we started hiring a big building saying it's a clinic, but then it turned out that people want to die at home. So we changed the concept into ambulant teams, and these teams are formed with doctors and nurses out from the region. So if you live in the north of Holland, you have a doctor from the north and a nurse from the north who's got a training in the life end clinic and has to report to the life end clinic, but they are in their own region.
Don't forget, Netherlands is not as big as United States. You had a question? Yes? Yeah.
Of the 42 cases of psychiatric euthanasia in 2013 that you mentioned, do you have the data on the ages of those people?
Now I'm looking at Petra. Do you know something?
It's open, it's public knowledge. Everybody can see it in the review committee reports, and you can see that on the internet. So I don't know it by head, because I've read the cases, but I don't know. But what I know that all cases were very, very, very severe suffering. For years and years, I think the youngest patient was 32, something about that, and most were elderly from about 80, and the most extreme I can remember was someone who was raped when she was 5 years old, and she went to, in the war, she went to the camps, and she married a husband who beaten her all her life, and at her 80th she couldn't go any further anymore, and well, she had psychiatric help and support for all her life, but in the end she got euthanasia.
Could you possibly share with us the circumstances of one or two of the 42 successful applicants?
Well, you just heard one of them, I think.
Yeah, okay. No more?
Well, they're all very different.
Okay.
They're all very, very different, and they all have in common that it's long time suffering, 10, 20 years, no feelings. But our far more keen on suicide, because they have to decide for themselves, is it suicide or is it unbearable suffering? And so they have now conferences and media attention about, we don't want any suicides anymore in the Netherlands. And then I don't know if they're going to succeed, but that's their goal. So that, you know, the people who are really suffering unbearable are standing out, and that everyone knows this is a case that can't be cured. But it's all kinds. It's schizophrenia, it's depression, not feeling you're in your own body. I don't know how it's called.
As far as I've seen the reports, I mean, first of all, of course, it is reports from all over the country, from a different number of doctors. So it is not one organization helping all those 42. So it is less easy. Like Erika can tell what she has done, and she knows every patient she has been helping. So that's, but mainly, I mean, I think the principle is that you should be suffering unbearably and hopelessly. And that is because of a psychiatric condition. And that can be a severe depression where the patient already received 24 times different antidepressants. And let's say 5 years ago, I heard psychiatrists saying, you know, this one doesn't help, but I have read that next week there will be a new one, and that is so good, so let's wait and see what that one is doing. That movement has changed.
Yeah.
All right. First, Faye.
Sure, I remember both questions. The Chabot case, which was, I don't know, 12, 15 years ago, didn't that determine in a way that psychiatric patients could be helped? Oh, the other part of the question is, are there any psychiatric cases where the competency is not found? They're not competent.
The Chabot case, I think it's much longer ago, really.
Shall we ask Chabot?
No, is he here? Oh!
He's here. I saw him sneaking in.
Thank you, Rob. The Chabot case, the Supreme Court verdict was in 1994, so it's exactly 20 years ago. And yes, you're right, Faye. This was a case that was considered by the Supreme Court as a psychiatric case. And they said, irrespective of the source of the suffering can be unbearable. The only problem in psychiatric cases is that it takes at least one extra consultant, doctor, psychiatrist, who has seen the patient himself. So there is the due care criteria for psychiatric patients was then laid down should be more, more than the usual standard unbearable suffering. To evaluate that, you need, apart from the scan consultant, a specialist in the particular depression area or whatever the patient kind of diagnosis has. Is that an answer?
So your case had to do with not the second consultant to see the patient.
Well,
Sort of determine that do this to psychiatric.
I had, in fact, 4 psychiatrists sent my 40-page document notes about the conversations, and they were divided. 2 said, I don't see any other options than honoring her wish, and the other 2 said, no, she should have morning therapy or be clinically admitted against her will. So they were split, the 4 psychiatrists, and then I decided to go ahead. And the criticism of the Supreme Court was not that I had gone ahead, but the criticism was that none of those 4 had spoken to the lady herself, themselves.
Okay, get an answer? Just the big chief walks in and he has an announcement.
Yes, unfortunately it has to do with security. The police and hotel
So are you
security.
carrying a gun right now?
No. The police and hotel security have become increasingly concerned about the protests.
Suicidality and a wish for death, and I would like you to clarify that. And I worked a lot as a psychologist with people with major dissociative disorders who had multiple suicide attempts, so I wonder if you could comment on that. I'm not sure because I'm not a psychiatrist. It's difficult for me to go into specifics, really. Is there anything I could answer about?
Well, maybe we have to refer to a doctor so we can refer to Petra, and maybe afterwards. Otherwise, Boudewijn would answer.
I'm not a psychiatrist myself as well, but what I've learned from my colleagues, psychiatrists, that they say that there is a difference between suicidality and well thought about death wish. And they are now developing methods to exclude those two groups, the suicidality group and the well thought about death wish. And I think that's an important development because you don't want to give help in form of euthanasia to a patient who is has a suicidality problem. So I think that's a development within the psychiatry. And what you said about the kind of patients, you work with disordered... multiple disorder patients, yeah. It's always difficult, but what I see that psychiatrists do nowadays when they have a request, a legal request for euthanasia, they have excluded everything and every protocol the patient has been through before they say, well, there's no other possibility and the evidence that your suffering is unbearable and helpless is clear, so that's the reason why I'm going to help you.
And I think, of course, what I started the discussion with is that, of course, the question of competence is very important. And I mean, I remember years ago when we started with all the, let's say, the normal euthanasia cases, I know that some family doctors consulted a psychiatrist to ask if the request was from a competent person. And nowadays, most GPs think that they can assess the competence of the patient when he or she asks for euthanasia. But if you go to complicated psychiatric disorders, multiple disorders, there's the question about, is this patient competent? Is this patient knowing what he or she is asking? Is major. That is why the second psychiatrist should be consulted anyway. That's the extra which Boudewijn has done.
But it's only in the guidelines and not in the law.
No, it is a professional guideline, and actually the only problem is that it is a professional guideline for psychiatrists. So if a family doctor has a psychiatric diagnosis with a patient, he is professionally not obligated to consult a psychiatrist. He is sensible if he's doing it, but it is not a legal obligation. But that is, I agree with the two of you. It is the start of a change. It is immensely different from 6, 7, 8 years ago. All right, who has more questions?
I was curious, you
Yes.
have electroconvulsive therapy in the Netherlands? Yeah. So are there guidelines about how many treatments a person has to have?
Okay, Margot, thank you very much.
Yes.
For your
Thank you all for